All right, Dr. Sohi, thank you so much for joining us. Really appreciate it. So you recently gave me a colonoscopy. I am religious about those because of past results that I've had, but it got us talking after that about medical disparities. We're going to get to those in just a second. First, a little bit of personal information about you. You are from Louisville, right?
I am. I born and raised. I grew up here.
And tell me, like, where did you go to school? Give me just a couple of tidbits.
Sure. So I went to KCD for high school because when people talk about where do you go to school in here, they mean where did you go to high school?
Good
And
point.
then I left and I went up to Harvard for my undergrad, and I went to medical school at Tufts University, which is also in Boston. I met my husband up there, and so we couples matched, where we basically did our residencies in the same city. So he's an ophthalmologist, and I did my internal medicine residency. So we moved to Chicago. We had a big city there as well. And then I did my fellowship in gastroenterology at Rush in Chicago. But I always knew I wanted to come home. Always. This is home. I had a beautiful experience growing up here, and I wanted that for my kids as well. And my family is here, my parents and my brother and his kids. So it's just been really great to be back. And I've been back for about 10 years now.
What led you to the medical field? Why did you say, I want to be a doctor?
Growing up, I think I always knew I wanted to be a doctor. My father's a physician. He's a cardiologist, and he is probably one of the longest practicing physicians in the city at this point. He is still practicing. He's currently teaching at the university. So it was always sort of a part of life. And I remember when I was a child, he would take me into the cath lab with him, and I would sit behind the wall and just kind of watch and learn. And I always was interested in the human body, always interested in science, and I was always interested in doing good for others. And I just feel so blessed to be in this field because it's a field where I make my living taking care of others and doing good for others and helping them be well.
Well, one thing that we talked about, and it was front and center for you, and you said, I really want to talk about medical disparities. So I know it's something near and dear to your heart. Let's start that with colonoscopies and colon cancer, because so much about things is prevention and access. So let's talk about colonoscopies and colon cancer, because we have seen it start to trend to younger people getting it in a lot in the Black and brown communities. So what is it about colon cancer that's so insidious and is hitting those demographics harder?
Well, I mean, colon cancer is a very common cancer. So it's the second most common cause of cancer-related deaths in the United States, and it impacts about 4 to 5% of Americans. So these are no small numbers. They've never been small numbers. It's a huge public health problem. And for GI, it's a big public health calling because there are things that we can do to screen for and prevent it. What we do know is that it is affecting younger and younger people. We don't yet know why, and it might have something to do with our diet and our lifestyle, which we can definitely talk about more later. But we also know that outcomes for colon cancer do vary by race, gender, and ethnicity and age, and that it is more common in African Americans. African Americans have a 20% higher rate than Caucasian Americans, and are also 40% more likely to die from colon cancer. So there is a disparity there for sure.
Now, when we talk about that, is it because of the prevention? Is it because of access? Is it because of education? What do you think are the overlying factors with that?
That's a great question, and it's probably multifactorial. I think we're going to end up talking about health disparities in general. And so as we talk about this, this is just like one subset of how we see health disparities being a problem. There are social determinants of health. Imagine if you don't have insurance and you have rectal bleeding. How do you get it taken care of? You're less likely to get it taken care of promptly, right? In addition, lower socioeconomic areas, which can be more associated with people of color, have food deserts. There's just not access to good, nutritious food the same way there is in other areas. It may not be safe to be outside sometimes. So in terms of exercise, which we know is associated with health, people may not have as much access to that as well. So not eating well, not exercising, we know that these are associated with things like obesity and tobacco use and alcohol use, which are all associated with higher rates of colon cancer.
And then once diagnosed, I guess too, if you don't have those preventative tests, it could be advanced when you find out about it.
Exactly. We do need better access to screening, but we also need better access to treatment and care. So we said screening rates are lower and later, and time to treatment is actually longer too. Treatment being surgery or chemotherapy. There was a recent GI study in one of our main journals saying that time to treatment is prolonged in the African American and Latino communities. So these are real problems with real data to support that they are issues, and we just have to figure out how to get around them. Screening rates are as low as 15% in some of the minority populations. That's pretty low. So we have a lot of work to do.
I was going to say, what should that number be?
I guess we're looking at screening rates. We want them to be 100%, right? We want everybody to be able to get screened. And the nice thing about the colon cancer screening is it doesn't have to be a colonoscopy. That is a gold standard, but there are non-invasive stool tests. There are ways to screen so that if there's any sort of resistance to screening, because people don't want to undergo a colonoscopy, there are at least other options out there for people, but we just need to get them to them.
And the heartbreak, of course, is if caught early, it's such a treatable cancer. It's when it's, in those final stages that it gets to be so deadly.
Exactly. So, that's exactly right. So we really need to push for early evaluation, and then early treatment as well.
Let's talk about too, just that I want to make sure that people know about this. You're so emphatic when you talk about plant-based diet and the good that can do in really taking a look at those eating habits, right?
I am. That's a big passion of mine. I am plant-based myself. We know the majority of people are not. So when we talk about plant-based, there's several different terms, I guess. There's being vegan, which is being 100% plant-based and not eating animal products. And that typically is associated with an ethical choice. And it doesn't necessarily have to be healthy, right? You hear about junk food vegans. You can definitely eat a vegan diet and not be healthy. Then there's being plant-based, which is being pretty much eating predominantly or 100% plants, not eating animal products, but it's done more with the intent of eating whole foods, eating things that are less processed, eating things as close to the source as possible. There's a new term that's come out lately that I really love, and it's called being plant forward. And I think that is the thing that is probably most accessible to people, which is that if you do eat meat, if you do eat animal products, the idea is that you eat predominantly plants. You eat predominantly fibrous, colorful food, and you do eat meat and you do eat animal products on the side, but the main thing that you eat is plants. And that is, eating plants is healthy for your body. We know that. There are so many arguments. There are so many different diets, the Mediterranean diet, plant-based diets that suggest that a diet that's rich in a variety of plant-based fibers is good for us. So I just really want to encourage people to get more plant fibers into their system.
And when you talk about that with the gut, you were telling me before we started recording that there's so much science with that, correct? About the healthy things that happen with that.
There is. So the newest and most exciting field in medicine, well, gastroenterology for sure, but I'm biased, but in medicine is looking at the gut microbiome. So one of the trendy words you hear a lot is gut health. And what does gut health mean? And when we talk about gut health, we're really talking about the health of our gut microbiome. And what that gut microbiome is, it's the trillions of microbes that live in our digestive tract, not just bacteria, but also viruses and fungi. And they live in this really beautiful symbiotic relationship with us where they do things for us and we do things for them. So some of the things they do for us is they make substrates like things called butyrate, which nourish our colon cells. They make vitamin B, they make vitamin K, and we're just scratching the surface of what we know about the gut microbiome and what it can do for us, because we see links with the gut microbiome and problems with the gut microbiome, which we call dysbiosis. We see links with dysbiosis and things like depression and anxiety, immune system dysregulation. The gut is one of the largest immune organs in our body. We have a lot of immune cells in there. Things like heart disease, diabetes. So our gut health really is important for the health of the rest of our body. And when we think about, well, what makes a healthy gut? What do our gut bacteria want to eat? They want to eat plants. They want to eat lots of plants and they want a diversity of plants. So there was a study looking at people who eat a variety of plants compared to people who eat a less variety of plants. And what we know is that people who eat 30 or more different types of plant fiber a week have a more diverse gut microbiome than people who eat 10 or less. And a diversity in the gut microbiome is what's considered health in the gut microbiome. So what that means is that we want to eat lots of plants, but we want to eat lots of different types of plants. And 30 sounds like a very daunting number, right? That's a lot of different plants. But if you take into account that you can include herbs and spices, you can include grains and beans or legumes, it's actually not that hard to get, but it also can be fun, right? So we were playing a game with our family a few weeks ago where we had a list going up on the fridge and we were each trying to reach 30. My kids and I, and my husband kind of participated, but we were each trying to reach 30 and trying to see who could reach 30 as quickly as possible or who would win. My point is that you can do it in a fun way, but also 30 is the goal, but I'm plant-based and my family's plant-based, right? So we eat a ton of plants already, but for someone who's not, 30 may be overwhelming. So start with 15. Start with saying, well, I'm going to try to introduce one new plant, one new vegetable into my diet per week, and go to the store with new eyes and say, well, I've never had this before, whether it be a purple cauliflower or whether it be sugar snap peas or something that you've never had, and take it home and try it out. That's how it starts, is tasting new stuff.
But I agree with you too. It's also re-educating the public, right? And it not being daunting and people going, I've never done this before. How do I do it? So it's getting that information out and the access to that information again, which is what we always go back to, those words, access and education.
Yeah, 100%. And it seems daunting. It seems daunting to anybody, but particularly if you live in an area where you don't have access to a lot of fresh fruits and vegetables, it's even more daunting. And that's where we get back to the disparities, right? It can be done, you can definitely get fruits and vegetables from the freezer area, and it doesn't always have to be fresh to be healthy. But if you have no idea where to start and your community is not set up to support you in this, it can be really difficult.
And I wanted to switch over to a little bit with COVID because it really I was reading some of the information that you had sent me, because it's those vulnerable communities that really get hit hard in any crisis. And COVID was more proof of that, correct?
100%. The COVID pandemic has completely highlighted the racial disparities that we have been studying in medicine for years and we know exist, but it just brought everything to the forefront. We know that the pandemic has sickened, hospitalized, and killed people of color at higher rates than other people. And there's so many factors, right? There's increased risks of exposure, unequal access to testing, unequal access to higher quality care, higher rates of underlying medical conditions associated with the poor outcomes, and less access to vaccination.
Even just where those sites were located.
Even where the sites were, exactly, even where the sites were located, they may not have been located in minority communities. And this is not just in our area, but also throughout the country.
Well, worldwide.
Nationwide. Yeah, like I know one physician was giving an example that somewhere in New York, they did have some sites in some Latino communities, but the people administering the vaccines did not speak Spanish. So there's barriers everywhere that we don't even think about. Reliance on web-based vaccine registration, everybody was trying to jump in the moment they could, but if you are living in a community that doesn't have access to technology the same way as someone else, there's a barrier there. Barriers like work obligations and limited childcare options reduce people's ability to chase vaccine appointments. It's much more accessible now, but at the very beginning, when vaccines were just rolling out and people were trying to grab them, that causes a disparity.
And I know that's why some African-American churches at the time also ended up picking up the phone and calling their members, because many were older and they didn't have access to the internet. It was daunting, if you are familiar with the internet, to make those appointments. I can't imagine if you didn't have access to any of that.
Exactly.
I did want to go into just some strengths and weaknesses in Kentucky, how we do compared to the rest of the country when it comes to those racial and medical disparities.
Yeah. So interestingly, the Congress created this National Healthcare Quality and Disparities report, which has been put out since 2003, looking at the overall quality of healthcare and the disparities in the general population. And they divide it state by state. It's been going on for 17 years now, and it's something that I actually didn't even know, but it's nice to know that that this is happening. And so we can actually look up the data for our own state and we can see where we stand. Now, the metrics are not, they don't cover everything, right? But there are metrics like, women of a certain age, have they been offered a mammogram? And how do you break that down by race? Does that, is there equality there? Our state, according to that database, is doing actually pretty well. But that's good because there are targets that we can look at. Still, though, there's things like implicit bias in medicine. We need to think about how can we further improve this, because that's just one step.
Is the medical field looking at this overall and starting to tackle this? I guess with people who might hear this, what can we do differently? What needs to be done differently? And is the medical community now addressing it?
The medical community as a whole, I believe, is the New England Journal of Medicine, which is kind of our pivotal journal. And, this is accessible to anybody. You go on there and you look up, medical inequality, and you'll find tons and tons of articles and tons of things that have been done looking at inequality and looking at studies and what we can do. What we've known for a while is that disparity is there. You can't deny it. And so now what we have to do is figure out what we can do about it. And that's kind of where the research is going at this point, and that's where the steps are being taken. We know that there are disparities. We know that there are things like explicit and implicit bias that need to be taken into account. We know that there are cultural barriers as well. But ultimately, I think what it boils down to, this is not everything, but we know that we need to dismantle these structural obstacles that our society has to equality.
What do you think is the biggest health threat in Kentucky, if you had to name one?
The biggest, just one.
I know. Well, I'm okay. Yeah, go with how many you need to.
Well, we were talking earlier about the opioid epidemic and how that is a huge threat, and obesity is a huge threat as well. So I think those are probably the two largest ones at this point.
And then I always like to end on a hopeful note. What gives you hope in the medical field?
Oh, so much. I think for me, the COVID pandemic has highlighted just how rapidly science can evolve and respond to crises when we need it to. I know people have looked at the way medicine has evolved over in the past year, and in some people it's caused a lot of mistrust because they see doctors saying one thing and then turning around a few months later and saying another thing. And what they're seeing is that this is how science works, right? We evolve in our knowledge, and it just usually happens a little slower than it did in this past year. But just to see how quickly we were able to evolve and create a vaccine that 95% effective is like unheard of for a vaccine. It's pretty incredible. If you think about it, a lot of people get the flu shot every year, and that's like 50 or 60% effective. So this is incredible. So I do have a lot of hope for the future that science will rise to what we need. I also feel like there's been a really good shift in medicine towards preventative care. I think we need to push it even further, but I think that's huge too, because there's so much that we can do to prevent diabetes, heart disease, obesity, and diet is just one of the things that we touched on, but things like stress reduction, things like exercise, time out in nature. These are all things that we can do. I want people to realize that they have a lot of control over their own health. Your body is only one part of it, and the genes that you were born with, that's only one part of what is going to determine your health. So much can be determined by what you do, how you live, what you do for yourself. And, we're working on that, but I do have a lot of hope that that's the direction we'll move in.
Well, and I thank you. I felt in such good and capable hands for my colonoscopy, and I'm a regular with that because of what I have found, with what's turned up with results, and to know that that is a test I have to get. So thank you so much for your knowledge and my colonoscopy.
Well, thank you. It was an honor. It was.